Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth. I'm your host for tonight's program on men's health. This is a great time to ask questions about any kind of health concerns, including incontinence, prostate issues, kidney and bladder concerns. Just call the phone numbers at the bottom of your screen. The number here, if it's not flowing across your screen, is 218-788-2844 or toll-free 877-307-8762. Our panelists this evening will be happy to answer your questions. Please welcome Dr. Gail Baldwin, a family physician with the VA Clinic in Superior, Wisconsin, Dr. Jake Powell, an internal medicine specialist with St. Luke's Internal Medicine Associates, and Dr. Paul Tonkin, a urologist with Essentia Health, Duluth Clinic. Our volunteers from the medical school answering the phones tonight are Paula Goosefriede, Cheryl Pearson, and Linda Liskowitz. And now on to tonight's program on men's health. As we start out, I'd like to define a few terms just for a background as we work on the program tonight. Dr. Tonkin, you're a urologist. Could you tell us a little bit about what urology is and what the urinary urogenital system is?
Yeah, urology is basically the study of the urinary tract as well as the male reproductive tract. And so a lot of our issues that we deal specifically are related to the kidneys, bladder, prostate, and men, and then women usually kidney and bladder problems.
Gail, we talked earlier about prevention and screening. Do you want to talk a little bit about what prevention is, just to lay the groundwork for tonight?
Okay, well, prevention is when you try to prevent the onset of illness. So you do things that are healthy behaviors, such as maintaining a healthy weight, exercising regularly, eating proper foods.
And Dr. Powell, the final ground piece that we want to put together is prevention. Do you want to discuss that just briefly too?
Or screening, perhaps?
Or screening, did I mix up? Yeah, okay.
That's okay. Yeah, so screening is when it's kind of a term we use to describe when we go looking for something that generally at the time isn't causing the patient any symptoms. Common things we screen for in patients: in men, prostate cancer, colon cancer; in women, breast cancer and colon cancer. So it's looking for disease in the absence of symptoms, trying to catch it early where we know we can make a big difference in treatment and outcomes.
Our discussion earlier, Dr. Baldwin and I, and actually Dr. Tonkin too, had to do with the prevention aspects. Gail, what do you think are important things in prevention of problems with men's health?
Important things in prevention? Well, I think that men need to make sure that they maintain a good, healthy lifestyle. They exercise regularly. They maintain a good, healthy weight. They eat properly. I think sometimes people forget that what we use as food and fuel makes a huge difference in how our bodies grow and reflects how we develop disease. So anyone who's obese is likely to have more problems with high blood pressure, diabetes development, probably more problems with arthritis as well. And if people aren't exercising well, then problems with joints, problems maintaining good weight, things like that.
Dr. Tonkin, you jumped into this discussion a little earlier too, and bringing up smoking. Do you want to talk about that a little bit?
Yeah, one of the things that's come out recently is just the connection, or really the role of the urologist in helping us quit smoking. And basically, smoking is related to a lot of problems in the urinary tract. And one that a lot of people don't understand is bladder cancer. Most people know that smoking causes lung cancer because you breathe in smoke, and obviously if it's in the lungs, that could cause cancer. What I try to tell my patients is that lungs aren't just a big plastic bag in your chest. I mean, if you ever held a lung, it's weighs several pounds. It's full of blood vessels. So I explain to them that the toxins that are in your lungs get absorbed into the bloodstream, go to the kidneys where they're filtered, and the job of the kidneys obviously is to filter out toxins, gets in the urinary tract. And I tell my patients, unless you urinate 24/7, that urine with toxins will sit in your bladder. And so the classic location to find bladder cancer is right on the bottom part of the bladder where those urine sits with the toxins. So I tell all my patients, if you have blood in your urine, you got to take that seriously. It's a classic story for a lot of my male patients. Oh yeah, I had blood in the urine about a year ago. It went away, so it was probably nothing. They come in, advanced bladder cancer a lot of the times, unfortunately, and that's a major lifestyle change. If you catch it early, it's really kind of a minor problem. It's something you can kind of control and tends not to really make a big impact in your life. So,
Jake, I think a lot of us have also fallen into the habit of asking about erectile dysfunction or ability to get erections. Do you want to talk about that just a little bit too?
Sure. Very common problem in male patients, really starting at any age, 40s to older in life. Risk factors for erectile dysfunction are also things that can affect other organs as well. So not only is it's something that can reflect your overall health in addition to being a problem with your partner. There's the risk factors for it are the same things that are risk factors for heart disease: smoking, overweight, high blood pressure, diabetes. All those things affect your blood vessels, and erectile dysfunction is essentially, for most men, it's a blood flow problem, and there's vascular disease in the blood vessels that are involved, and they're just not working properly. And so it can be a reflection of overall health. It can also be present in some men who are otherwise generally healthy, but it's one of those things that is sometimes reflective of other issues going on as well. There's lots of treatment for it. There's medication treatment, which gets a lot of ad time on TV, and it's a very common issue. So something to sit down and talk to your doctor about. It's something to make an appointment for and have a discussion about treatment pros and cons, and looking for other diseases that might be present as well.
and to piggyback on what Jake is saying, basically, if there's any young men in our audience tonight listening, really the take-home message should be, if you're young or middle-aged for that matter, and you have
That's
ED,
young.
yeah, absolutely. 50 is the new 40. And if you smoke and you have erectile dysfunction, the first move you should do is to really quit smoking. There's a lot of good data, suggesting that link, and so a lot of men don't know that, and damage is done in that process until they realize that. So that's a really helpful piece of advice for those men.
Probably the most important piece of men's health is not to smoke,
It's right up there for sure.
because it fits printed every system. Dr. Baldwin, we talked a little bit about screening. Do you want to talk about, let's talk about prostate, because that tends to be the one that we end up screening the most for, it seems like. What do you do as you take care of the veterans over at the VA?
Well, there's some controversy about whether or not to screen certain people for prostate cancer. So I think that's a work in progress. But what I tell all the veterans that I take care of is that by about age 50, unless there's a strong family history to recommend screening earlier, that we would do prostate cancer screening. And there are two methods that we use. One is to digitally or with a gloved finger feel the prostate through the rectum to check for lumps. And the other is to do a blood test called a PSA, which will sometimes screen for an elevation in the prostate-specific antigen that is sometimes present in higher amounts with cancer. It can be present in higher amounts for other things as well. So just the elevation of a PSA, or the presence of a lump for that matter, doesn't say, oh my gosh, you have cancer. But it does mean you have to look a bit closer. And right now, what I tell folks is that screening has been previously recommended by age 50, and that particularly important for people who have family history or have had toxic exposures that increase their risk. So for the veterans I take care of, Agent Orange exposure seems to increase their risk of the development of prostate cancer. So I screen all of them.
The question that comes in from here in Duluth is, do you consider not taking tests or surgery for prostate cancer a good idea? Anybody want to bite?
I'll bite. I feel the eyes looking at me right now. I agree with Gail that the data on PSA screening is controversial right now. It's not real obvious that PSA screening saves lives. I think the take-home message on the screening piece would be, from my standpoint, if you're between age 50 and 70 and you're a real healthy, fit man, you should at least speak to your either primary care doc or your local urologist about what the pros and cons of that conversation are. I think this question's asking something different. I think this question's asking, well, once you've been diagnosed with cancer, does that mean I need surgery or some sort of definitive therapy? And I think there's emerging data talking about active surveillance, which basically is the acknowledgement that the vast majority of cancers we diagnose in terms of prostate cancer is in fact low grade and probably poses a very small threat to your life. That doesn't mean that the disease couldn't progress or couldn't potentially metastasize, but the risk of that cancer killing you is relatively low. And I would offer that, I think in this region there's a lot of really high quality urologists right now who are really in tune with that. And so I think regardless of what institution may be your home base, certainly discussion on active surveillance makes sense. I would tell you it really depends on the person. It's not one size fits all, but I think most institutions in the region have an active surveillance program currently.
Flomax has entered into the questioning a couple of different times. One, why is it important to tell your eye doctor that you're on Flomax? And secondly, is Flomax a mechanism that can be taken forever, and is it a way of avoiding surgery? And Jake, I don't know if you want to address that first.
Sure, I can answer both of those questions. The first question about telling your eye doctor, I believe it's only specific for people who are having cataract surgery, but Flomax can affect your healing process following cataract surgery. So that's the big reason you want to tell your eye doctor. The second part of that question, Flomax is a medication that is now available in a generic form, which helps cost, but it's a medication that helps to relax the muscle wall of the prostate and helps men to, by doing so, helps men to empty their bladder more efficiently. It's a medication we use commonly for men with symptoms, not so much of prostate cancer, but benign prostate enlargement, or BPH. And it's one of the first-line medications we use. It's not the only option. Once started on it doesn't mean you need to stay on it forever. It can potentially help you avoid prostate surgery, and fairly effective in most men.
As long as we're on the prostate and we're talking a little bit about prostate cancer, what do the different stages of prostate cancer mean? And maybe, Paul, that falls back to you.
Sure. If a man comes in to see a physician and is found to have prostate cancer simply because of an elevated PSA where the exam was normal, PSA was high, therefore he got a biopsy and was diagnosed with cancer, that's called T1C disease, which is certainly early stage disease. Any sort of stage 2 disease means it's confined to the prostate itself, not outside the walls of the prostate. Stage 3 cancer generally means that it's confined to the pelvis, but outside the prostate. Stage 4 disease means that it's spread to other organs. Prostate cancer often spreads to the bones, is a common place for prostate cancer to go. So clearly the higher stage disease you have, the worse your prognosis. And I think one of the topics that came up tonight already is that this early stage disease, while it is cancer, may not pose a real threat to your life. And so it's in that population, those are the majority of the cancers. And we're just trying to be more thoughtful as to how to treat those specific cancers.
Let's switch gears and jump over to HPV. And Dr. Baldwin, we talked a little bit, I think several of us did earlier, about HPV and the strong recommendation that all young females get up to puberty and on. There's now a discussion, I think it's been released for males also. Mm-hmm. Do you want to discuss this a little bit for us?
Well, I think that HPV is the virus that causes warts, and in women can cause cervical cancer. There are certain types that do that. The risk of cervical cancer is one of the reasons that HPV vaccine is given to adolescent girls or young women. Usually try to do it before they become sexually active. The idea being that giving it to young males would help to reduce transmission and so reduce the disease in the population generally. And of course, the potential for reducing just the warts, the presence of warts.
Jake, do you talk to young men about testicular examination? I know there might be just a little ahead of where your practice starts.
No, I have, most of my patients are older, but you have a percentage of young men, and testicular cancer is one of the most common cancers in young men. It's not real prevalent, but of the solid organ cancers, it's reasonably common. So just like we recommend a self-breast exam for women, it's not a bad idea to recommend a self-testicular exam for young men. And it can happen at any age, but in your 20s through 40s is probably the most common time for presentation. You're feeling for anything that feels like a abnormal lump, bump, something that maybe feels the size of a marble or a pea that shouldn't be there. And if you find anything ever, go see your doctor and get a good thorough exam from your doctor.
Thank you. Dr. Baldwin, this one this is a question for you. This person has a low testosterone and uses gel. What are the side effects? And
Oh my.
you might want to jump in on that one.
Yeah, no, I'd be happy to take that. You know, if you use
don't use it.
testosterone gel, which is an effective way to receive exogenous testosterone, a couple of things we aware of there. You know, one is you have to be careful how you apply it, because if you are using the family hand towel and then you know, little Susie comes and washes her face with it, you can actually spread the testosterone gel onto a bystander. From a standpoint of what it can do to the man, anytime you take exogenous testosterone, it can cause prostate growth, which if you don't have prostate symptoms in your urination, you could develop them as a result of that gel. If you are at high risk for cancer, or if you have prostate cancer, it's not advisable because there's concerns that testosterone could accelerate the prostate cancer.
Dr. Baldwin, we've had 2 questions on coffee brown urine. What causes coffee brown urine? And
Well, the 2 most common things to cause coffee brown urine are either blood or bile. And so a liver disease can make your urine go brown, and blood, dark blood in the urine can make the urine go brown.
this one person was on amoxicillin clavulanate as a medication, and with that had that happen.
I don't know why that would
Jake, you're the internist
Not a
here.
common side effect from that medication that I'm aware of. Some medications can turn your urine color, and that particular antibiotic is not one that we usually associate with that.
And I remember your answer, the bile and blood is the main ones. So go see your doc, right?
be. Yeah, for
See your
sure.
family doc. 75-year-old that incontinence comes and goes. Does that mean that there's something else could be medically wrong? Is there something that might be stopping it beside the prostate? Whoever wants to bite?
There are a lot of causes. There's a lot of causes for male incontinence. There are some more concerning sort of reasons, like a spinal cord issue or something like that. But certainly the most common cause in any man, especially a 75-year-old man, would likely be some bladder irritability, which could be secondary to an enlarged prostate. A lot of my patients don't totally understand the fact that when you have an enlarged prostate, your bladder has to squeeze harder to get that urine through the prostate, which causes the bladder muscle to get bigger and stronger, which I guess superficially sounds like a good thing. Big and strong muscles are a good thing. The problem is, in the bladder at least, the bladder will start to ignore some other regulatory signals in the body, and so the bladder will squeeze when you don't want it to. And if you're out in a social setting, that'd be quite embarrassing. So almost certainly related to the bladder, ruling out prostate as the primary etiology would be the key for that individual.
Dr. Baldwin, why can't my husband urinate when he takes Claritin D?
Oh, the decongestant part of this medication can stimulate a certain nerve function that then creates a difficulty allowing the bladder to release, or allowing the sphincter to release, so that the bladder can freely pass the urine through.
Dr. Tonkin, lady calling for her husband. He's a 48-year-old male with a hernia in the reproduction area. What should he do? Does he need to have surgery? How long is the recuperation? What should the surgery be?
Yeah. Well, thank God for wives, right? Calling about us
That's
guys.
right.
Yeah. If it's truly a hernia, which would be in the groin area, generally speaking, those get fixed, especially in a guy under 50 who's probably active. There's probably no real value in letting that go on for a long period of time. The reasons for urgent intervention would be if there was pain, if there was changes in the coloration of the skin, if there were bowel changes, that would all suggest that bowel might be entrapped in there. Now, just to kind of go one step further, sometimes people have what's called a varicocele in the scrotum, and they interpret that to be a hernia, or they might have a hydrocele in the scrotum, which they misinterpret to be a hernia. And those are different things. So just real quick, a varicocele is a distension of veins around the testicles. So that would look, not to be crude here, but for the fishermen out there, it would look kind of like a collection of night crawlers in the scrotum. That's what a varicocele looks like. A hydrocele is just a big sac of fluid, which is pretty tense. And if you were to turn off the lights and shine a flashlight behind it, the light would glow through it. And so those are kind of quick bedside sort of things that we do to distinguish between those three different etiologies.
Jake, probably for you, 60-year-old male on ultrasound had a 5-centimeter cyst on the upper right kidney. Is this dangerous, and what do they have to do about it?
Right. Generally not. Usually, first of all, kidney cysts are very common. They're a very common, what we would call an incidental finding when we image people's abdomens for other reasons. The vast majority of the time they're benign. The radiologist is able to look at it either via ultrasound or CT and say with a high degree of certainty whether it's a cyst or something more concerning for a malignancy or cancer. Typically, if we feel confident with the decision that it is a cyst, no routine monitoring is necessary. There are unusual kidney conditions where the kidneys are filled with many cysts. That's a completely different entity, but a single solitary cyst, usually a benign finding, nothing to worry about.
Dr. Tonkin, what are the feelings on the treatment of hormonal treatment of prostate cancer? We've kind of touched up to that a little bit. Do you want to, are there pros and cons?
Yeah, well, hormonal treatment would be appropriate for a man who either has metastatic disease, because that goal of that treatment is to really slow down the cancer, it's not really to cure it, or a person who really isn't fit to have surgery or for other reasons couldn't have radiation to cure the cancer. Every once in a while you'll come across a young man who for some reason has been given hormone therapy, and that is really inappropriate. And I'd also argue that for people who are about to have surgery, for no reason should you ever have hormone therapy if you're being at all considered to be a surgical candidate, for two reasons. One, it makes the surgery much more technically challenging. And then number two, it actually makes the margins of the specimen being removed inaccurate, which is a problem for a variety of reasons. So it's an appropriate treatment for usually an older person with a very high PSA, assumed to have metastatic prostate cancer. Slows cancer down usually for a few years. Very common treatment.
77-year-old nighttime urgency on oxybutynin and wants to know if the anticholinergic and memory loss in older, if it's related to the memory loss, if that anticholinergic is related to memory loss in older people. Is that true? Jake, falls in your area, maybe.
Shot at that. So oxybutynin is in a class of drugs we use to help control bladder urgency, help control the muscle from contracting. They do have other side effects, especially in seniors and elderly. It can impair your cognition. I don't think they've ever been shown to actually cause permanent memory loss or permanent kind of brain damage, so to speak. But they certainly can affect your ability to think in the short term and can at times cause some confusion in some people.
And if I could just jump in, not so much on the oxybutynin or the ditropan, but just the concept of getting up at night. Men in the audience should understand that there is a correlation between sleep apnea and getting up at night. And so a lot of my men who come in who say that, yeah, I get up 5-6 times at night, you ask them, are you a snorer? Yeah, I snore. Does your wife ever, kick you out of the room? Yep. Do you ever stop breathing? Yep. Okay, well, you don't need to see me. You need to go down the hall and see the pulmonologist because you probably have sleep apnea. And what's happening there is you're getting awoken from your sleep apnea. You wake up and you're like, yeah, I could urinate. And then you go and it's, just kind of misinterpretation of your symptoms.
Dr. Baldwin, if the urine smells fruity, what could that be caused by?
Diabetes. Sometimes a fruity smell to the urine will be diabetes, a sweet smell, kind of could be you ate something too.
Is the smell of urine important? I get lots of calls from the nursing home. Well, the urine smells bad, so we need a culture. Is that important?
The urine will reflect sometimes just the foods that you eat. Some certain foods will make the urine smell odd or maybe even have a different color. Asparagus is notorious and will cause a change in the smell of urine that not everyone can detect, but is often interpreted as, oh my, bad smell. So,
is Flomax the safest drug for an enlarged prostate? Least side effects?
It's as safe as any other drug on the market. I mean, you know, Jake you mentioned it is now in a generic form. I think it's a widely used drug that's safe. I'm not going to give a personal endorsement to Flomax, but
How high can one's PSA go before surgery should be considered? You got 15 seconds.
loaded question. The highest PSA I've seen is 4,000. If it's over 10, you got to take it seriously for sure.
I want to take this opportunity to wish you all a very happy holiday season and extend a Merry Christmas to my good and our good friend and mentor, Dr. Ben Owens. I want to thank our panelists, Dr. Gail Baldwin, Dr. Jake Powell, and Dr. Paul Tonkin, and our medical school staff, Paula Gustfriedi, Cheryl Pearson, and Linda Liskowitz. Please join me when we return on January 9th for tackling the problem on weight and weight problems when my panelists will be Dr. Matt Bettendorf, Dr. James Donovan, and Dr. Steve Park. Thank you for watching. Good night, and again, a great holiday season to you.